So we've got 5 minutes for you to give us a presentation, and then there's 10 minutes for us to ask you some questions. So what would you like to tell us about your patient today?
This is Mr. Jones, 64 years of age. He's a window cleaner, is a smoker, 40 cigarettes a day, has angina, had surgery undertaken 3 years ago. They have stents put in. He's on GTN spray, atorvastatin, ramipril. He's presented with painful callosities on the plantar aspect of the right first interphalangeal joint, the right second metatarsal phalangeal joint, and the right fifth interphalangeal joint, and there's hallux adductor valgus on the left foot.
Is that your presentation, or is there anything else you wanted to add?
No.
You're finished?
Yep.
Okay. So you've just given us a bit of a description of presenting complaint and some elements of medical history. Have you undertaken any further assessments today?
What do you mean?
Any assessments that you would undertake as part of routine clinical practice based on the presenting history that you've given us here?
Well, because of the hallux adductor valgus and the callus on the first interphalangeal joint and the second met, I did joint range of motion, and there's a bit of limitation on the first metatarsal phalangeal joint on the left foot. The left hallux was fine. Bit of ankle joint restriction and dorsiflexion on the left foot. There was a bit of restriction on the ankle as well.
So what's the significance of the findings of those assessments that you've undertaken?
There's limitation in joint movement.
And so what are the implications of the limitation of the movement?
It's going to get overloading, like we're seeing with these calluses on the second and the fifth and the first.
So could you be a bit more explicit about what limitation is causing that callus to be there?
I don't know what you mean.
Well, you've mentioned a few joints that you've assessed. There's a bit of limitation at the ankle, there's a bit of limitation at the first. Could you explain to me functionally what's happening to that's resulted in those lesions present?
Well, the first isn't dorsiflexing properly, and therefore it's gone to the interphalangeal joint. So that's why the callus is building up on the interphalangeal joint.
So how much dorsiflexion did you find when you assessed the joint?
I'm not exactly sure in degrees, but not much. I don't know, 5 degrees?
5. So it was 5 degrees of dorsiflexion. So what would you typically expect to find? How much dorsiflexion would you expect to find in a normal joint if we're saying that this is limited?
More than the 5 degrees. 45.
45 is normal.
Yeah.
Okay. So can you describe to me functionally what is happening during the gait cycle to result in these lesions that we're seeing today?
Well, as a patient's walking, the first metatarsal phalangeal joint isn't functioning properly because it's only got 5 degrees of dorsiflexion available to it. So it's shifting up to the interphalangeal joint, and there's a bit of it that's shifting over onto the second metatarsal phalangeal joint, so that they're still going to be walking through it, but it causes overloading over on those areas. And there's a bit on the fifth as well, so they're just shifting the load.
So what condition is present in the first?
What do we mean?
You've described the name, or you've described, the motion available, but what would we call that condition?
Hyperkeratosis.
The condition affecting the first metatarsal phalangeal joint.
Osteoarthritis.
Okay, but what do we call the condition affecting the first metatarsal phalangeal joint? That's the pathology. You've described the pathology. It's osteoarthritis. But what is the name of the condition?
What, like? Don't know.
Okay.
Osteoarthritis.
Okay, you mentioned that the patient has HAV of the left foot. What's your definition of hals ductal valgus?
It's where you get a medial deviation of the first metatarsal and a lateral deviation of the phalanges with a sort of a medial prominence.
Okay, can you discuss significance around degrees of deviation for a diagnosis of HAV to be given?
Don't know what degrees.
Yeah. So how many degrees of deviation would be required in order to diagnose hals ductal valgus?
10.
Is that a guess?
No, it's 10.
Okay. When you identified the left first MTPG as having HAV, what differential diagnosis did you consider?
Well, it's obviously hallux adductor valgus.
So you hadn't considered any alternate diagnosis?
No, because it's obviously hallux adductor valgus.
Okay. Have you given any consideration to the fact that HAV is presenting unilaterally?
It sometimes does that. I've seen it like that before.
Why?
Maybe one foot's bigger than the other.
Have you tested that?
No?
So what else could it be?
Well, the guy's a window cleaner, so might be something to do with how he climbs the ladder and maybe balances on one foot on a rung of a ladder.
Really?
Possible.
Okay. So we've been focusing mostly on functional structural assessment here. Were there any other assessments that you've undertaken that you would consider undertaking in this particular patient?
Well, I looked at the skin. The skin's in pretty good condition.
Okay. Anything else?
Could check his pulses, I suppose. Could do a vascular assessment.
Did you do that today?
No,
Why not?
because his skin looks fine. And as I was treating the callus, the temperature of the skin, temperature of the foot's all right.
Is there anything in this patient's history that would put him at an elevated risk of demonstrating signs of peripheral arterial disease?
To So he's had angina in the past.
And what is angina?
It's where you get a cramping in the heart because you've got reduced circulation to the heart. So, but he's had that sorted out. He had surgery, and he hasn't had an attack.
Okay, so is there a relationship between the coronary arteries and the peripheral arteries with regards to disease?
What, like atherosclerosis, you mean?
Yes. So what is atherosclerosis?
It's where you're getting a laying down of lipids and atheroma in the wall of the artery, and it narrows the artery down, and it means you can't get enough blood through.
Okay. And how would you naturally assess the presentation of atherosclerotic disease in the lower limb and foot?
You do a vascular assessment.
And what would that look like?
You might check the pulses. So, dorsalis pedis, posterior tibial, could do anterior tibial, but if you're doing dorsalis pedis, it comes off of anterior tibial. You do temperature gradient, capillary refill time, might use a Doppler.
So do you think your assessment of the skin was enough in place of all those other tests that you've listed?
Well, he doesn't give it, the guy's a window cleaner, he's busy and he's active, and the skin was all right, so it hasn't given me any history of ulceration or anything.
And the fact the gent smokes 40 a day hasn't changed your opinion on that at all?
I can do it if you want me to.
It's a bit late. Should you have done it prior to us sitting down with your patient?
I suppose because it's an exam, yeah, maybe.
So if this wasn't an exam, would you do anything differently?
Might do a vascular assessment.
Might do a vascular assessment.
Uh-huh.
Can you tell us how you're going to manage your patient today?
Reduce the callus, and I've spoken about using the foot file on the callus lesions, but he's a busy guy, so don't know how successful that might be, and we'll see him again in 8 weeks' time.
Okay. So other than regular reduction of his lesions at home, you're not thinking about managing the redevelopment of these lesions through anything we can do therapeutically?
There's no point putting any padding and strapping on because he's a busy guy, he's a window cleaner, he's around water a lot, and so he's, pads are going to get wet. I suppose you could make an insole for him.
You suppose?
Uh-huh.
Okay, what would that insole look like and why?
It would be a simple insole with padding in it with a U to the second and a wing to the fifth.
And what's the function of it?
To deflect pressure
And where's that pressure going to?
elsewhere on the foot,
Where particularly on the foot?
across the other metatarsals.
What material would you make that from?
A material that would allow redistribution of pressure, so not a cushioning material. Because I'm aiming to get it shifted from those areas. But I don't know how he's going to tolerate insoles. These shoes are pretty tight fitting, so.
Okay, thank you.